Um, Good afternoon, everyone. I'm Anu from ONG department. This afternoon, I'll be presenting regarding pain management of obstetric and gynecology. So, going to the outline of the topics, today I'll be covering on the introduction, objectives, the benefits of implementing labor pain management, labor pain client charter, principles of pain relief in obstetric patients, pain stages of labor, labor pain management and baby-friendly hospital, pain assessment in labor and management of labor pain management of other obstetric procedures, and minor gynecological procedures. So, coming to the introduction, is for improving quality of care, especially reducing stillbirths, maternal and newborn deaths. Symptoms of pain in obstetric patients may indicate sinister events and is to reduce the morbidity and mortality by early detection. Contraction is a desired effect of labor process, but not the pain. Pain management influences post-delivery care as well. The objectives here is to improve the understanding of labor pain, recognize and assess patients' pain level effectively using pain assessment tools, provide appropriate and safe interventions in labor pain management, and to improve the patient satisfaction during the labor process. So the benefits that we can get is for better intrapartum care for the patient, better monitoring of the labor, decrease the anxiety and the stress for the patient, reduce chance of fetal or neonatal risk from poorly managed labor pain, and for successful breastfeeding and postnatal recovery. The labor pain client charter is for the healthcare personnel to strive to provide you with a better labor experience. The healthcare personnel will give prompt attention to your labor pain. The healthcare personnel will monitor your labor pain throughout your stay, and the management of labor pain will be individually tailored using appropriate intervention. Principles of the pain relief in obstetric patients. Obstetric analgesia might be required throughout pregnancy till post-delivery. The method should not cause more side effects to the fetus or infant and least maternal side effects. The analgesic technique should exert little or no deleterious effect on uterine contraction and voluntary expulsive effort. Coming to the pain stages of labor, first stage, the labor pain is visceral and poorly localized, diffuse and dull and vague. It is usually referred as a periodic or builds to a peak, produced by distension of the uterine or the cervical mechanoreceptors. And the main pain fibers on this will be T10, T11, T12, and L1 spinal nerves. Coming to the second stage, uterine body contractions and distension of the lower uterine segment, stretching of the pelvic ligaments, the somatic pain in nature and well-localized, sharp, definite, and intense. Plus ongoing visceral pain from the, as I mentioned during the first stage of the uterine contractions, cervical stretching, somatic pain from distension and rectal pressure. These are more from via the pudendal nerve, a somatic derivative from S2, S3, and S4 sacral nerve roots, including the T10 to T12 and L1. So this just a diagram. From T10 to L1 is mostly during the first stage and all together during the second stage, including the pudendal nerve. And during the dermatomes of the sites of pain during childbirth, as you can see in the next diagram. Pain stages of labor, third stage, after delivery of baby until expulsion of the placenta. Usually this stage has quite minimal pain. Post-delivery, perineal wound, uterine involution, caesarean wound, and others like back pain, leg pain, and breast and headache. Factors that may influence labor pain: physically, age and parity, stages of labor, physical condition, prolonged labor, dehydration and starvation, frequency of contraction, maternal position in labor, and delivery interventions. Psychology, perceptions and attitude towards labor, knowledge of childbirth and expectation of pain, fear and anxiety, prior experience of pain, support and environment, socioeconomic status, and culture and beliefs. Coming to labor pain management in baby-friendly hospital, labor pain depends on the woman's threshold and other factors. Measures must be taken to alleviate the pain and provide comfort during labor, ensuring a pleasant experience to aid care of infant, recovery, and breastfeeding post-delivery. Pain management in labor is in line with baby-friendly hospital initiative. So this is the pain management that we use throughout the hospital. And in the obstetric chart in gynecology, this is in ward where pain score is seen in the chart. And also this is in our pathogram, which the pain score is directly below the contractions. So this is the flowchart diagram. This is for the pain management in patients in labor in hospitals for the paramedics. First, we greet the patient, clinical assessment, counsel the patient about the non-pharmacological methods, teach patient for pain assessment tool, assess the pain score, and accordingly, we will move on from there. And this is for doctors. Informed by the staff nurse, greet the patient, clinical assessment, and counseling, pharmacological methods desired. Either we can go for Anthenox, intermittent opioids, or epidural, depending on the pain score. So management of labor pain modalities of treatment, this is for non-pharmacological. According to this, what we can provide for the patients is reassurance. We can explain to them regarding the pain and stages of labor, information about the interventions that you are going to give, relaxation techniques by breathing technique or meditation, touch therapy by soft tissue manipulation, distraction techniques like reading, listening to music, watching TV, electrotherapeutic, transcutaneous electrical nerve stimulation, or others like aromatherapy and companion physical or emotional support. Coming to the pharmacological management of labor pain. First, I will talk about paracetamol. It's a simple analgesic used to relief of mild to moderate pain, may be given orally, per rectum, or intravenously. Mechanism of action is the prostaglandin inhibition, weak inhibition of peripheral cyclooxygenase activity with apparent selective of COX-2. So its indication for mild to moderate pain relief. The dose is oral, rectal, or IV, 1 gram 6 hourly to a maximum of 4 gram per day. For adult of more than 50 kg. Contraindications if patient has allergies to the paracetamol, hepatic failure, or hepatocellular insufficiency, or HELP syndrome. Precautions in such patients with hepatocellular insufficiency, severe renal insufficiency, G6PD, or chronic alcoholism. The next common drug that we use in our labor room here is pethidine, synthetic opioid with a low oral bioavailability. Is available in parenteral formulation only. Preparation is in a vial, injection 50 mg per ml. Route is either IV, IM. IV is preferred because IM shows variable absorption and unpredictable analgesic effect. So the dose is 1 mg per kg, and last dose should be administered estimated 1 to 3 hours prior to delivery to prevent neonatal depression. It's normally metabolized in the liver to active metabolite norpethidine, which has a longer half-life and is neurotoxic, which may cause tremors and convulsions. Risk of accumulation is greater in the renal impairment patients. Uses include perioperative analgesia, obstetric labor analgesia, procedural analgesia such as minor surgery, trauma, and reduction of fractures. Contraindications if patients are on antidepressants within the previous 14 days, bronchial asthma, increased intracranial pressure, head injury, or brain change, severe hepatic impairment, and convulsive disorders. Usage in obstetric patients is given an intermittent bolus technique for labor analgesia, 1 mg per kg. Last dose should be administered estimated 1 to 3 hours prior to delivery, and usually given together with antiemetic such as metoclopramide or promethazine. Next will be tramadol. It's a weak opioid analgesic and noradrenergic and serotonergic properties that may contribute to its analgesic activity. Available in oral or parenteral formulation. Preparation is vial injection 50 mg per ml. Route is oral, IV, IM, or rectal. Dose is 1 mg per kg, 4 to 6 hourly. It's a perioperative management of acute pain and labor analgesia. Other uses includes procedural analgesia such as minor surgery, trauma reduction factors. It benefits as a weak opioid with a good analgesic for mild pain. Lesser overall side effects compared to morphine, especially in respiratory depression. Contraindication, concurrent use of tricyclic antidepressant, selective serotonin reuptake inhibitor, and major tranquilizers and pethidine. Usage in obstetric patients is given intermittent bolus similar to pethidine, 1 to 3 hours before delivery. PCA tramadol can be considered for labor analgesia, but is often require combination with other drugs to improve analgesic efficacy. Anthenox is another available in our hospital. It's a 50-50 mixture of N2O with oxygen. Anthenox is used for its analgesic properties to provide short-term analgesia for minor surgical procedures and labor pain. Nitrous oxide possesses synergistic effect if given with other analgesics and sedatives. Indications in labor pain and in such a pediatric inpatient or outpatient setting. So benefits of Anthenox is a ready-to-use medical gas mixture of 50% nitrous oxide and 50% oxygen that provides rapid and safe and effective short-term pain relief, effective pain relief and sedative effect without loss of consciousness, rapid onset and offset, properties that help to reduce patient anxiety, easy and self-regulated administration, and minimal side effects. Contraindications is in pneumothorax, bowel obstruction, embolism, and other maxillofacial injuries and head injury. Usage in obstetric patients, educate labor analgesia for many patients, administered using self-administered and administered handheld mask. Patient should start to inhale as soon as she senses the contraction coming and to maintain throughout contraction phase. Effect will take 45 to 50 seconds for the onset and lasting for 1 minute. Coming to epidural. This is mostly done in patients we suspect for severe PE or cardiac problems. So the prerequisite for this is the patient in labor room. There's no fetal distress. She's not in established, she is in established labor. Cervix is not fully dilated as epidural analgesia needs time to work. No contraindications such as thrombocytopenia, coagulopathy, sepsis, hypovolemia, high ICP, severe heart disease with fixed cardiac output, and allergic to local anesthetic drug. So pathogram findings should be noted, consent should be taken, appropriate equipment and supplies of resuscitation should be checked, oxygen supply, suction apparatus, anesthetic drugs, a good working intravenous line, epidural procedure to be performed under aseptic technique, and test dose is recommended to ensure no intrathecal injection has occurred, and epidural 2 mils of 2% of lignocaine. So the maintenance is once established to continue epidural analgesia until after completion of the third stage of labor and any necessary peritoneal repair. Few modes can be given for maintenance of epidural analgesia: patient-controlled epidural analgesic, or continuous epidural infusion, or intermittent boluses. Patient should be cared for in any position comfortable to her. If in supine position, ensure she is in left uterine displacement to avoid atrial compression. The care and observations during epidural. The patient should be monitored closely throughout the period of epidural analgesia. Monitor the maternal blood pressure, the pulse rate for every 5 minutes for at least 30 minutes, subsequently 15 minutes, and the next 30 minutes, and then hourly. Continuous fetal heart monitoring with intermittent CTG tracing 1 to 2 hourly. The respiratory rate, pain score of less than 4 is acceptable. Pain score should be documented before and 15 minutes after initiation of epidural anesthesia, after which hourly charting should be done. If the pain score is more than 4, we should call the anesthetist in case there's a risk of incomplete patchy block or epidural catheter dislodge. The level of sensory block hourly should be assessed. T10 sensory block is adequate. If the patient is going for LSCS, then the sensory level should be at least at T5 to ensure adequate epidural anesthesia. To document any lower limb weakness, sedation score, and epidural anesthesia to be continued until completion of third stage of labor. So post-labor epidural analgesia, all patient receiving epidural anesthesia must be reviewed post-delivery till 24 hours to ensure the block has receded. Some patient may end up in lower cesarean section due to maternal or fetal indication. Thus, assessment of conversion of epidural analgesia to epidural anesthesia spinal must be done. To assess for any side effects, complication, as well as patient satisfaction, document the fetal APGAR score, and further follow-up and closer monitoring should be paid. Should patient require any further management due to complications such as post-dural puncture headache, urinary retention, neurological deficit. For any major complications such as post-dural puncture any neurological deficit, patient should be referred to the anesthetic team, such as when patient complains of frontal headache, neck stiffness, and visual disturbance, and nausea and vomiting. So this is the obstetric labor pain ladder. As you can see, the location is on on one side, ward or labor delivery unit, and below is whether the pain score is less than 4 or more than 4. So according to that, we can see as the ladder goes up, the more the analgesia is needed, such as from parenteral opioids to the PCA to the epidural. So this is the pain management for minor procedures in ONG. Obstetric, episiotomy and perineal repair under local anesthesia normally would give lignocaine or bupivacaine. Manual removal of placenta to be done in OT under anesthesia. In case of no OT available or urgent indication, IM pethidine 50 mg to 100 mg can be given with IV midazolam in titration 1 mg until patient is slightly sedated but arousable. Pethidine with Anthenox can be given. Post-delivery may use NSAIDs and paracetamol. In minor gynecological procedures such as secondary suturing under local infiltration, lignocaine and bupivacaine is given. Manual vacuum aspiration, colposcopy, hysteroscopy, or wound dressing. Counsel breathing technique, IM diclofenac sodium 50 or 75 mg. IV or IM tramadol can be given, and IM nalbuphine 10 mg can be given. IV PCM 1 gram, Anthenox, and consider oral NSAIDs, including paracetamol opioids. Thank you.